Which hospital do you work in, Rachel?
St Thomas's.
Thomas's. Oh, St Thomas. Go. Right. Okay, we are up and running. Okay, excellent. Morning, everyone. Welcome to another session with us. You are most welcome. We're very lucky today. We have Rachel, who is a nurse who works in St Thomas's in London. And she is going to talk to us today about triaging and assessment, mainly in adults, because we've done quite a lot of pediatrics. So mainly in adults. The slides will be available on the Facebook page, and we are also starting up a Telegram channel, so they'll be on there too. Rachel, thanks very much. Over to you. Thank you.
Thank you so much for having me this morning. Like Marcus said, my name is Rachel, and I was a senior staff nurse based in an emergency department in central London at a hospital called St Thomas's. In this hospital, we saw between 400 and 600 patients in our very busy emergency department every day. And what I'd like to talk to you today about is how we triaged or assessed. We'll talk about what the word triage means in just a moment, but how we assessed and processed those patients as they came into our department to make sure that the sickest patients got seen first, and those that needed immediate treatment were able to access that as quickly as possible. So I'm just going to show you my first slide over here. So just to give you a bit of an introduction as to who I am actually on the left-hand side here. This is me and my family. I grew up in Thailand, but as you can see, I have a very strong connection to Burma. And on the right-hand side is me standing outside of my hospital. So I just want to say, these are all reflections that I have from my own practice, things that I've been taught, but I acknowledge and understand that we all work in very different contexts. So please, through the course of the presentation, if you have any questions, please pop them in the chat if you feel confident to do so, or ask a colleague about any of these things, and understand that this is coming from where I have worked and my experience, but it may be slightly different where you are as well. So to move on, so what is triage? Triage actually comes from the word trier, which means to separate and to sort out. It's a French word. Acuity-based triage is a way of sorting patients so that the sickest patients are found quickly, so that they receive care that gives them the best possible result for the best possible outcome. So Nicole and Brooker say the process of assessing patients to determine who to prioritize based on clinical need. As we probably all know, assessment is the key to good nursing care. We need to be able to assess our patients to understand what they need. And prioritizing that care, so deciding who gets what care and when, must be done efficiently, but also compassionately. We need to make sure that our patients who we care for get the right treatment at the right time in the right place. And that could be the place where we are working and we meet them, or it could be that they need to be sent on to another place. It depends again on your context. When I was working in central London, we had a very well-equipped tertiary centre, which means that we had kind of the highest level of speciality care you could give for certain conditions like heart attacks. So we had a cath lab. But for example, stroke or neurological conditions, we had to send patients on to another centre. So it was even more important that we identified these sick patients as quickly as possible so they could be transferred. And that might be the same in the area you work in. Perhaps you cannot give them the treatment you need where you are, but you need to make sure that they get quickly to the place where they can receive treatment. So I've got a little case study, and although Marcus said that I was going to do adult, this case study is actually a pediatric case study. Just because I had the information available, I will speak mostly about adults going on. I apologize, Marcus. So this case study actually is a combination of real events this is my mother in the photo here on the left-hand side. A combination of a case that she cared for and a case that I've cared for. So 2 generations of nurses. So to begin, I'm just going to read out the case study and then we'll go through how I or my mum conducted our assessments. So it is a busy morning in a local health clinic. It is noisy and crowded. Patients are normally seen in the order they arrive in, with some waiting several hours to be seen by a nurse or a doctor. You, as a nurse, are called over by a distressed mother holding her 1-year-old child. They have been waiting since first thing in the morning. The child has diarrhea and vomiting for 3 days and is not eating or drinking. So I was wondering if anyone is able to type in the chat and is feeling confident and willing, what would be the first step of your assessment of this child? Just give it a minute or so. If not, we can move on and I can give you my answers.
Give the chat a minute, there'll be something here.
That's fab.
What do you think, everyone? What is your first step in assessment? It doesn't matter if you're wrong, it's just a guess.
Fab. Excellent. We've got people already messaging in.
Fantastic.
So someone has said airway, someone has said dehydration status. Anybody else have any thoughts? Both of those, another dehydration status. Excellent. You guys are beating me to the punch. This is brilliant. Excellent. So we've got lots of dehydration. I think maybe you have guessed my scenario already. Okay, so I'm going to move on. Thank you so much to everyone who's put in an answer. That's fantastic. So I would, in this situation, first of all, and it may seem really simplistic, but part of this process is about familiarizing yourself or getting used to having a very structured approach. And sometimes the most obvious thing we think is not worth mentioning, but I like to start with the really obvious and then sort of work my way through. So the first thing I would do in this situation is take the mother and child to an appropriate triage location. So you may have met them outside the door of the clinic, or you may have met them in a very busy waiting room where it's very noisy. So the first thing I would say is we take the child and the mother to somewhere that is safe. So somewhere where you can safely conduct an assessment, somewhere that is appropriately private. And I know that can be very difficult depending on how small your space is or how busy your space is, and somewhere that has suitable equipment that you need. Now, as we go through, you'll see that actually for my assessment, I'm not going to use a lot of equipment for this initial assessment. Predominantly, what I'm using is history from the mother. I'm using observations that I can see, things that I can feel, and I'm not going to use much complex equipment, but you may need equipment for other assessments. And then the second thing I'm going to do is start a structured assessment using the ABCDE approach. Some of you may have used this already or have been taught this in your practice. And then as part of that, I'm going to be conducting a physical exam of the child and collecting relevant history from the mother. So I'm going to take you through my ABCDE and what I found with this particular case study. If there's anything that doesn't make sense or that you want defined, please put in the chat as well. And we will be going through ABCDE in more detail after this case study too. So first of all, as one of our lovely colleagues here has already suggested, we're going to assess the child's airway. Now, to put this into even more context, what I would do is once I have found my safe, private place to triage, particularly with infants and children, I would make sure that they are stripped of all clothes so I can properly observe the child from head to toe. That might not be the case for all adults, but I think it is important to remember that we need to be able to see our patients. And particularly for assessing airway and breathing, to be able to see the rise and fall of the chest is really important. So airway, I determined that this child's airway is patent, so there's nothing stopping or blocking the airway. I notice when I come to breathing that they have an increased work of breathing. They're really struggling for breath and their respiratory rate is 65. Moving on to cardiovascular or circulation, I notice that the child's hands and feet, their extremities, are really cold and that they have a weak peripheral pulse. So they have a weak pulse that I can feel and the pulse is going at about 190 beats per minute. I do a capillary refill. So I do a press, probably in the central capillary refill. So I press down for 5 seconds and remove my thumb. And the time that it takes for the skin color to change back to normal is more than 3 seconds. Moving on to disability, I do something called an AVPU scale, which we'll talk about later. And my result of that is that the child is P or only responding to pain. And I note that they are drowsy and floppy. And then with exposure, I've talked already about how we've taken the child's clothes off so we can see the child completely. I notice they have reduced skin turgor. We'll talk about that as well in just a moment. And I notice that their eyes appear sunken. So I think as many of you in the chat have already identified, I think we already have a sense of what the main concern is with this child. So like my lovely colleagues have already said, this child is demonstrating signs of clinical dehydration, but also this child is demonstrating signs of shock. What I would like to emphasize here is, although it's really good to have in mind a possible diagnosis, the process of triage is not necessarily about diagnosing the problem. The process of triage is about identifying those danger signs that make us concerned about this child and prompt us to make this child a priority above all the other patients in our waiting room. So it's not because this child is dehydrated that we want to make them a priority. It is because this child is significantly sick and needs early intervention, needs early treatment and input in order to improve their outcomes. My question to you is, if this child had been seen when they first arrived, because if we look back at the case study, we see that they've been waiting in clinic several hours. I'm just coming back here. Yeah, waiting for some hours. Do you believe the treatment that we would need to give and the outcome potentially for this child would have been different? So that's my question. If the child had been seen straight away, would the treatment and the outcome be different for this child, do you think? There's a big yes in the chat. Excellent. So yeah, that is the purpose of this case study, is just to demonstrate that actually, if we do appropriate triage and we identify our really sick, really vulnerable patients who are demonstrating these danger signs, and if I go back to my ABCDE, some of the things I would identify as danger signs are their increased work of breathing, particularly their rest rate, which is very elevated even for a child of this age. The fact that they have tachycardia, so high heart rate, and that their capillary refill is raised. Those are all significant danger signs for me. And also their reduced consciousness level, their AVPU, the fact that they're only responding to pain, and these other visible signs that we can see in the exposure section, where there's reduced skin turgor and sunken eyes. All of these are danger signs for me. And just to emphasize again, early intervention is critical, particularly with a case like this, because it leads to better outcomes. So moving on, just to recap again, why do we triage? We triage so that patients get seen at the right time, in the right place, and then go on to receive the right treatment. We might not be administering that treatment ourselves as part of the triage process. We might just be moving them on to someone else or somewhere else where they can receive that treatment. But the key is that we are assessing them at the right time in the right place so that they can go on to receive the right treatment. And like I said before in the previous slide, the key is not to necessarily diagnose, but to assess what immediate needs must be met. So we might not know, for example, if someone has a high fever, what is causing that fever. We might not diagnose that as part of our triage, but what we will do is we will see somebody with a high fever, potentially convulsing, or potentially with symptoms that suggest they could convulse. And we will make sure that person is moved to an area where they will be seen as quickly as possible, and they will receive the care they need. So again, who needs care immediately, who needs further assessment, and who can wait? Those are the three categories I would tend to simply triage people into. So when I see somebody, do they need care now that will change the outcome? Do they need further assessment? Or can they wait to be seen? And through all of this, like I said, we're identifying those danger signs that make us concerned for the patient and their well-being and prompt us to move faster to get them seen. So the triage environment. Before we go into the nitty-gritty or to the detail of triage, I want to talk briefly about triage space. Now, again, it's very different in the different places we work. This picture is of a busy waiting room, I believe, in Australia, but this looks very typical and very similar to the waiting room that was in the hospital that I work in. And although our places of work might be different, there are several universal principles that apply no matter where you are doing your triage. It could be that you're doing your triage in a small clinic. It could be that you're doing your triage in a larger hospital. But regardless of where, here are some key principles. The first is patient safety. Is the place where you are doing your triage a safe place? Now, this might mean a lot of different things in a lot of different places, but I would say, is the individual you are assessing, is the person you're assessing there safe? But also, are you safe in that place? So if you're assessing someone, and I find this particularly with adults, although it might be the case with children and their parents as well, if you have a very distressed or very angry adult, or you have an adult who's suffering severe mental health problems, sometimes you can be concerned for your safety as well. So make sure the area that you're in makes the patient feel safe, makes you feel safe. And the third consideration is there somebody else watching who is arriving to the clinic? Because you might be with somebody who is sick, but maybe, needs some further assessment. But as you're with them, someone else arrives who has even greater need of assessment. So are you able to see the door where people are arriving, or do you have a colleague who is watching the door in the waiting room? So those are all patient safety considerations. Secondly, is the room you're in appropriately equipped? Now, from the example I gave, you can perhaps notice that I didn't use any equipment for that brief ABCDE. All of the assessments I were doing, I can do either visually or I can feel. So I was feeling for a pulse. I was assessing cap refill with my thumb. I didn't do blood pressure on the child. I didn't take their temperature. These are all important components or observations that could have been done. But like I said before, our purpose is to identify danger signs. And if we can do that without equipment, then we don't need to collect more observations to confirm what we already know. However, if you do need equipment, or if you feel like you need equipment in order to more thoroughly identify that there aren't any further signs of concern, I would say make sure that that equipment is properly maintained. When I worked in Iraq, we had a stethoscope, which was great, and we had a blood pressure cuff, but the heat was so hot that it melted the tubes of my blood pressure cuff. So we weren't able to accurately collect blood pressures. So making sure your equipment is properly maintained is really important. Also making sure that your equipment is properly cleaned between patients. Because of COVID, we've become very aware of infection control and making sure there's no cross-contamination, so no passing of potential vectors or disease from one patient to another. So that's what I have to say about equipment. Thirdly, appropriate documentation. Now, you can do an excellent triage, but the key is to make sure that the outcome of your triage is achieved. And how you do that may have a large impact. Might be that, sorry, just lost my train of thought. 1 second, let me get back on. Yes, documentation. You want to clearly document what you have found through your process of triage in a way that others can read, in a way that you can easily transfer to someone else, and in a way that identifies that person in one of the 3 categories that I discussed before. Do they need immediate treatment? Do they need further assessment? Or can they wait? So this, on the slide here, you can see this is just a small example of like a quick way of documenting notes. And what I would say to make it even easier for you and the people you work for or your team is to make sure those notes are color coded. So I would use red for people who need immediate. I would use yellow for people who need further assessment, and I would use green for those who could wait. But it doesn't really matter about the colors as long as everybody in the place that you're working is on the same page and understands what those colors mean. And then the 4th thing I would say about your environment is patient privacy. Now, I practiced this session with my mother, who, like I said, is also a nurse. And when I talked about patient privacy, she laughed quite loud. And the reason she laughed is that she has worked in many places where it is very difficult to privately assess a patient because the area is so busy or so small. But privacy is important because you're more likely to have an accurate triage if the patient is in a safe space where they can, for example, expose themselves, take their clothes off while maintaining their dignity. You're more likely to see things that you need to see. For example, you might not notice significant bruising or unequal breathing if somebody still has their shirt on, but also the patient might not communicate important information with you if they feel exposed or vulnerable or without dignity. So it's partly compassion and care for our patients, but it also has a very practical application. So where possible, make sure you're able to triage patients in an area that is private. So is everybody okay? Am I talking too fast or going too fast or giving information that you already know? if anyone has any feedback before I move on. Thank you very much. That's very kind.
This is okay. This is clear. Thank you very much.
Oh, thank you. Excellent. So I will keep going at this pace. But
Yes,
again,
ma'am.
wonderful. Again, if I'm going too fast, please just let me know as I move forward. So I'm going to talk through a structured approach, specifically the ABCDE approach I used in the case study. And I am going to talk about how I then would categorize patients based on the findings from that ABCDE. Why do we use a structured approach? Why do I do ABCDE and not just go through in a different order? Well, my belief is that it makes us faster. So it makes us as clinicians faster at our assessments. And this means we can give time-critical treatment to life-threatening conditions. It helps keep people safe. It helps us improve our efficiency of resource use. So in many places I have worked, we have been very well resourced. We've had many medications, many pieces of equipment, but I've also worked in places where there are very few resources. So being efficient with how we use those is really important. And it improves our communication with other healthcare practitioners, and it helps us to justify why we have made the decisions we've made. So if I say someone is a red category patient, for example, I think they need to be seen immediately. It's much easier for me to say, this person is a red category patient because their airway is obstructed, or this patient is a red category patient because when I've done ABCDE, there are danger signs in categories B, C, and D. It gives greater strength to our argument. And so, for example, if I was working with a colleague who is a doctor and they have seen a lot of patients today, they're really tired, they see a crowded waiting room and they're, just feeling really concerned. If I say to them, oh, doctor, I think you should see this person because they look really sick, that doesn't have as much strength or weight to it than me saying to the doctor, I think you should see this person next because they have this danger sign, which I've identified in my ABCDE assessment. Does that make sense? Wonderful. So the categories of red, yellow, and green are part of the interagency integrated triage tool. So that is a tool that is used by different organizations across the world. It was developed by the World Health Organization. And like I've said before, red means urgent, they need immediate intervention. Yellow is a priority, they need further assessment. And green is non-urgent, they can wait to be assessed. There's a really helpful diagram. Like Marcus said at the beginning of this session, you can access these slides afterwards. And I will also send anyone who's interested, or through Marcus, my notes for this presentation as well. And this diagram will be on that. So like I said, it comes from the World Health Organization, who worked with the International Committee of the Red Cross and Médecins Sans Frontières to develop this. And it helps us identify danger signs through those ABCDE structure, and then allows us to move people into the appropriate category for them to be assessed. So this is the diagram for those over 12. So this would be predominantly what I would use in my work with adults. There is also a diagram for those under 12 because the parameters are slightly different. Looking at this is helpful because it helps us identify sort of normal parameters for things like heart rate, respiratory rate, temperature, oxygen saturations, etc. And then yes, for under 12s. So we're going to go through ABCDE, and I'm going to talk about some of the things that might come up in each of these categories. And again, this isn't about diagnosis. This isn't necessarily about treatment unless you need to treat directly in order to save that person's life. This is about the process of categorization and identifying those danger signs that would put people in the red category as opposed to the yellow or green category. So airway. So some excellent colleagues in the chat, their first response to the assessment of the child was airway. So again, we're looking at patency. So patency means the ability of air to pass through and into the lungs. Is there anything blocking or obstructing their airway? Can you hear any noise or feel their breath, or is it silent? This is really important because if you have a silent patient with an obstructed airway, they need immediate CPR. They need immediate resuscitation. But sometimes it can be very hard to hear. So you really have to be up close and personal with your patient. And I'm not sure if you have done basic life support as part of this course. I think you may have done first aid with Marcus already. But our first step of basic life support in the UK, we're trained to first assess the area to make sure there's no danger. And the first thing is to listen and feel for breath. So airway. If you have an obstructed airway, that's immediately categorizing your patient as a red patient because they need immediate intervention. Moving on to breathing. Now, respiratory rate is key. It's very often overlooked. When I was a university student studying nursing, our lecturers would always drum this into us. Respiratory rate is such a significant indicator of a deteriorating patient, somebody who is getting sick very rapidly, and also a decompensating patient. So decompensation is when the body is no longer able to protect or maintain those essential organs that you need for life. Oxygen saturations is a really important part of breathing as well. However, pulse oximetry may not be available. And that's okay because you can identify other significant danger signs from breathing without having to measure someone's oxygen saturations. If you have access to a pulse oximeter, it can be really helpful. What we found in my department during COVID is that some people can have really low oxygen saturations without necessarily showing the other visible signs we would look for. So in that case, it is important for us to measure their oxygen saturations. We call them happy hypoxics. So they look relatively well, but actually their oxygen level is very low. However, if you don't have access to this equipment, you can still conduct an assessment. So what can you observe without using a pulse oximeter? Can you observe any visible cyanosis? Cyanosis means sort of blue lips or mouth or tongue, any sort of signs that the blood is not being oxygenated well enough. These areas are not receiving enough oxygen and are therefore becoming discolored. You're listening for breath sounds as well. And again, this is about equipment available and your confidence and skill. So auscultation is the process of listening with a stethoscope. However, if you've not been trained in this or you don't feel confident, sometimes I don't feel confident auscultating patients, that's okay. It's about using the skills and the equipment that you have to make the best assessment you can. And so that's listening without maybe a stethoscope, maybe just putting your ear to the patient's chest or coming in really close to listen. You're listening for things like wheeze. You're listening for things like a lack of breath sounds on one side. You're listening for things like stridor. Now, stridor is a danger sign as well. I'd hope to share with you a short audio clip of stridor, but unfortunately I'm a bit nervous about how the tech will work. So I'll try and do an impression of stridor, but it's that like those sounds as if somebody is really struggling to get a breath out, and it can sound really distressing. Again, absence of breath sounds on one side. Listen, but what I would also say is feel. Now, we talked about exposing the patients and making them take off their clothes. If you place your hands on the patient's chest, can you feel both sides of the chest rising and falling equally? Or is one out of sync with the other? That can indicate things like a collapsed lung or a pneumo or a hemothorax. So those are also both significant danger signs. So it's about looking at your patient, accurately measuring their rest rate. It's about looking at your patient, observing for signs of cyanosis. It's about listening to your patient, and it's about feeling your patient. All these are really significant in breathing and don't necessarily require complex equipment. Moving on to C. So I said cardiovascular before, but we can also say circulation. Basically, it's about the circulatory system. The first and most significant thing is bleeding, catastrophic hemorrhage. Catastrophic means catastrophe, like the worst. So are they having significant bleeding from any place? For young women, you want to make sure they're not having any significant PV bleeding, so any bleeding from the vagina, any traumatic bleeding from an injury or trauma. And if they're bleeding, then they are not going to be able to, they're losing blood volume and they're at risk of hypovolemic shock. Hypovolemic shock is when you don't have enough circulating blood volume in order to function, to allow blood to circulate oxygen to your critical organs. So with circulation, we want to make sure there's no catastrophic hemorrhage. Some models will actually start C, ABCDE. So they'll look for the catastrophic hemorrhage first, and that tends to be the case particularly in trauma units. So the area that I worked in, if we were in the resuscitation bay and someone came in from the ambulance, having had, say, an accident, one of the first things we do is strip the person off of all their clothes and look for any major signs of hemorrhage. Moving on with circulation, we're looking at peripheries. So their hands, their feet, are they cold? Are they discolored? Like in the example with the young child. Then you're looking at pulse. So pulse, again, is something you can measure manually. It's one of the first things that I was taught to do as a student nurse. The first thing I was taught to do was to wash my hands properly. The second thing was how to take a pulse. And you're looking at the rate, so you're feeling and measuring the rate of the pulse. Is it fast or slow? Both can be danger signs. So if someone's heart rate is less than 50, then that is a significant cause of concern. And again, if it's an adult, if the pulse is more than, say, 100 to 150, specifically if it's more than 150, that is a significant danger sign. But as well as the rate, you're thinking about rhythm and you're thinking about regularity. Is their heart rate really irregular? Is it sort of going do, 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 do? Or with the rhythm, does it feel bounding? Can you feel a really strong pulse, or does it feel really weak? We're also thinking about capillary refill, and I talked about that briefly when we talked over our case study. You can do capillary refill on the peripheries. So with an adult, you can do it sort of at their finger. So you press for 5 seconds and then release. The other way to do it is to do it in the center, sort of on their trunk, and that gives you perhaps a more accurate assessment as well. So you're pressing for 5 seconds, releasing, and counting how many seconds it takes for the skin to maintain its normal color. And then blood pressure. So like I said before, blood pressure is an important measure, but if you identify any danger signs before you come to blood pressure, then you already know that the person is a red category patient. So you may not even need to do blood pressure. And actually the act of taking a blood pressure might delay you getting the patient to where they need to be. So unless all the other signs are normal and you're still concerned about the person and you think, I need to do their blood pressure just to check, then I would not be too concerned about blood pressure, particularly with your pediatric patients, because it's much harder to do blood pressure on pediatric patients, particularly the younger babies, than it is on an adult. So we will now move on to D. Now, disability is perhaps the most confusing category, because you think, oh, disability, what does that mean? Does that mean, you know, do they have a disability? But actually, disability in this case just is sort of a catch-all for a lot of different things that then come next in your assessment. So first thing with disability is pain. So pain can be a really complex and confusing thing to assess because pain is so subjective. Pain is experienced so differently by different people. So when you're assessing pain clinically, and particularly when you're assessing it as a danger sign or not in the context of triage, I find it really helpful to have this little set of descriptors that I work through. And I do OPQRSTU because it's the same in the alphabet, OPQRSTU. So O stands for onset. When did the pain start? P stands for provoking or palliating factors. Now, they're slightly confusing terms, but provoking is what triggers the pain and makes it worse, and palliating is what makes it better. So for example, chest pain is very complex and confusing because chest pain could be all number of different things. And what we want to do is to rule out the worst things it could be. So if we think about chest pain, we might think heart attack. But by going through this list of different factors, it can help us narrow down whether or not that is more likely or whether something else is more likely. So for example, with my assessment of, say, a young man who comes in with central chest pain, if I ask him to take a deep breath in and a deep breath out, if that has a significant impact on his level of pain, then I wouldn't rule out it being a heart attack, but I think, okay, if deep breathing is having a significant effect, is this more likely to be something like a costochondritis or something of that nature? I'd still do other assessments to rule out it being a heart attack or MI, but the type and quality of pain and what makes it worse and better can help me sort of guide my assessment. Next is quality. So I've talked a little bit about that already. Like, quality means sort of descriptors of the pain. Is it like a stabbing pain? Is it a pressure pain? Is it a sort of throbbing pain? Is it a burning pain? People use lots of different words to describe things like this, but there are certain trigger words that you think, so for example, with a heart attack or an MI, people describe a pressure typically. So if somebody says it feels like there's an elephant sitting on my chest or something like that, you'd be thinking, the quality of this pain is concerning to me. Region and radiation. So does the pain move anywhere? Does it go anywhere else? So an interesting example of this is ectopic pregnancies. Now, ectopic pregnancy, you might think, if they have pain, it's going to be in their stomach, it's going to be low down. But actually, a number of women I've assessed who've had ectopic pregnancies have had shoulder tip pain. They've described really bad pain in their left shoulder, sometimes their right, but more commonly their left, that they describe as like sharp and stabbing. And the reason why women who are having ectopic pregnancies describe this pain is that the phrenic nerve actually runs from near the fallopian tubes, the uterus, up past the shoulder. So they get this transferred pain. So although the problem is sort of around their uterus, their abdomen, the pain is transferred up to their shoulder. So if I hear a young woman or a woman of childbearing age complain of shoulder tip pain, immediately I'm thinking, I need to rule out the potential for an ectopic pregnancy, which is a medical emergency and a danger sign and would make them a red category patient. S, severity. So how bad is it? So we have a scale we use. We go from 1 to 10 is your pain. 10 is the worst pain you've ever had. 1 is very little or no pain. I really hate this scale. I'm going to be very honest with you. I think because pain is so individual to the person, it can be very difficult to understand, one person's 6 might be another person's 10. But if that is the only scale we have to use it as best we can. And what I would say is that as nurses who are seeking to be compassionate in our assessment, even if we don't believe that that person is in that much pain, we have to believe when they say their pain is 10 out of 10, we have to treat their pain for 10 out of 10. Which can be very frustrating because sometimes you think, that person doesn't look in a lot of pain. But then they say, my pain is 10 out of 10. I don't know that person's history. I don't know what pain they've experienced in the past. I don't know if they have chronic pain. When I'm first meeting or assessing somebody, it's really important not to make presumptions or assumptions about their pain, but to believe what they're saying when they say it's this bad or it's not too bad. Timing and treatment is T. So when did it start? And if you, for example, took treatment, so let's say they took 2 paracetamol, did that help alleviate the pain? And then understanding. So this is an interesting one. I think some people will come in and they'll be having chest pain and they'll have convinced themselves they're having a heart attack. So their understanding of the pain is that they're having a heart attack, which then increases their fear, which then increases their pain, which then increases their panic. So if you just take time to understand, okay, why is this person so afraid? What do they believe is going on? Then you can sort of help to reassure, and that process of reassurance can actually reduce their pain level as well. So moving on, because I'm conscious of the time. Within disability, we also have consciousness level, and this can be really important in identifying our danger signs as well. So it's an understanding of what their basic neurological function is. How awake or alert are they? So when we talked about the case study, if you remember, we talked about the baby being P. So what does P mean? Well, the AVPU scale is a really simple way of defining alertness. So A is alert, V, they are perhaps sitting with their eyes closed, they look quite sleepy, but when you say their name or if you say something to them, their eyes open and they become alert again. P, they maybe have their eyes closed, they look like they're asleep, but when you give them a painful stimulus, so in my department, initially we were taught something called the trapezium squeeze. You take your thumb and your finger and you find the trapezius muscle just above the shoulder here and you give it a really good squeeze. And that's quite painful. So if somebody, even if someone's deeply asleep, they will wake up to that. So that P and U, which is unresponsive. So you're squeezing them, you're trying to wake them up and they're just not waking up. Both of those are concerning danger signs. Moving on to disability continued. Related to consciousness level is altered mental state. So is somebody confused, irritable? That can apply to young children. The parent might just say their behavior is just not normal. They're more irritated, they're more confused than normal. Also can apply to adults, particularly older adults. Somebody who cares for their grandmother or grandfather might say they just don't seem like their normal self. They seem more confused. And we have different measures of consciousness that are more in depth and detailed than the AVPU I spoke about just now. These include the Glasgow Coma Scale and for children, the Blantyre Coma Scale. We can talk about those more in depth at the end if you have any questions, but they're just different tools for assessment of someone's conscious level. But like I said, if you've done the AVPU, which is the most basic, and they're P or U, that's when you start to become concerned. Disability also includes temperature. And I'd say with temperature, somebody may have a temperature, but that is not necessarily a direct danger sign. My concern and things that would make it a danger sign would be particularly high temperature or temperature along with, say, a stiff neck, convulsions, bleeding, or a reduced consciousness level. So that would make you think, is this person not only febrile, but are they having a febrile convulsion? Or are there other elements to this fever that are making me concerned? In addition to high temperature, I'd also be concerned about low temperature. So hypothermia is when someone is too cold, and that is also a danger sign because body function is significantly impacted by low as well as high temperatures. Moving on to exposure. Now, I talked at the very beginning when we were doing that assessment with that young child about exposing the patient. Now, you want to do this because you want to see the whole person from top to toe. And you want to do this while ensuring their dignity is maintained. You don't want to make someone strip off all their clothes in front of the whole waiting room. It doesn't give them dignity. And what you're looking for when you expose a patient is, like I said, back in circulation, signs of blood loss, external signs of injury. Do they have an open fracture, for example? Do they have rashes, swelling, or bruising that in combination with other factors make you concerned? Now, the important thing to remember again is this is not about diagnosis. You may see a rash and think, I wonder what that rash is. But is it significant for your triage process? Potentially not. Somebody could have a rash and be a green patient and can just wait. However, and I think, again, this is really important in the context of COVID and our awareness of infection control. If somebody has a rash, which to you looks like it might indicate an infectious disease, so for example, a meningococcal rash, you may have seen pictures of that. We can talk about that more at the end again, if that's helpful for you. But if you identify a rash that would indicate, an infectious disease, the important thing to do in that process is to isolate that patient and to make sure that even if there's somebody who can wait for further assessment, so likely not if it's suspected meningitis, but for example, chickenpox, then you are isolating them from the rest of your patients, protecting the rest of your patients from potentially catching that infection. So even if they don't get, categorized as a red patient, they will probably be categorized as a yellow patient and then put in an area that is separate from everyone else. Same with swelling and bruising. Now, it's important to note these things and to be aware of what types of swelling or injury might indicate a more significant presentation. One example I can give of this is something called battle signs. Now, this occurs usually behind the ear. It's a bruising that sort of comes down behind the ear that's not connecting to bruising on, say, the mandibular or around the jaw. It's very much localized to behind the ear. And you can also get raccoon eyes, so bruising below the eyes, and it's got to be sort of bilateral bruising. It's not just on one eye. This is particularly concerning, and this is a medical emergency and a significant danger sign, particularly if the bruising has occurred 1 to 2 days post injury. So let's say someone has fallen off a motorbike and hit their head. If they then present to you with bruising here or bilateral bruising here, it could signify a base of skull fracture, which could, if displaced, lead to paralysis or even death. So if you notice significant injury or bruising like that, that person needs immediate treatment and they are a red sign. So moving on, I'm just going to come back to the triage tool we spoke about earlier. So as you can see, you are checking the ABCDE priorities for red, the danger signs that would immediately make someone red, the yellow signs, which would mean that they need further assessment, treatment. And then once you've assessed whether or not, I don't think this person has any red signs, I don't think they have any yellow signs, then you might do some more vital signs. So check their heart rate, check their oxygen sats if you can, check their temperature if you can. And if they don't have any high risk signs, then you move them to green, which is they can wait. So I'm just going to briefly talk about this. So these are other high risk trauma criteria. So we've talked a lot about sort of a medical assessment of somebody. But other significant things that would make someone a red patient are to do with their history. So these aren't necessarily things that you have seen or observed or collected in your observations, but they're from the story that the person has told you or the person who's brought them in is telling you. So general trauma, so fall from a height of twice the person's height, any penetrating trauma, so something that is like stuck in them. The most important thing to remember with that is never try and pull something out. If something is stuck in the patient, leave it. Just leave it where it is and move them as quickly as possible to where they need to go to have it removed, usually surgically. Any kind of crush injury, so if their leg, for example, has been crushed between two motorbikes or two cars, anybody who has multiple traumatic injuries, so maybe they've hit their head, but they also have what looks like a broken arm or a big bleed, anybody who's been in a high-speed crash. So we tend to say in my hospital, anything over 15 miles per hour, but that can change depending on where you are. The person may look okay on your first assessment of them, but the risk of internal injuries that you cannot necessarily identify straight away is so high that they just need to go immediately for further treatment or assessment. And as you can see, other road traffic accident related history as well. Burns is also a very important thing to remember. Anything that's over 15% of the body surface area needs immediate resuscitation because we become so quickly dehydrated and can go into hypovolemic shock with burns. If you guys have access to it, and I will double check this, you can get a really good app on your phone, which helps you identify what percentage body surface a person's burns are covering. So you have the app and it has like a picture of a person and you like color in where their burns are. And then the app will estimate what percentage body surface they've been burned on, which can be really helpful because you can then say to whoever you're passing the patient on to, this person has approximately 30% body surface area burns. They need urgent treatment. The other thing is also threatened limb. So let's say somebody has a very cold left foot and you can't feel any pulses in that foot, and they're losing sensation in that foot. It may be pale, weak, numb, or swollen. Now that could be as a result of trauma, or it could be as the result of a blood clot, which is blocking circulation to that foot, and that needs immediate intervention. So that's a red sign. And then on the other side, you can see other high risk criteria as well, a lot of which we've talked about before. So moving on, triage in summary allows you to use the assessment and observation skills you have. So you already have these skills, I'm certain, to prioritize patients. And you're using this framework to identify danger signs so you can appropriately categorize the patient as red, yellow, or green. What I would like to say is be confident. I'm from what I've heard, you are wonderful, incredible practitioners. And this system is primarily to help support you to feel confident in the observations and assessment you are collecting, and to help you see patients as efficiently and as thoroughly as possible. This picture was drawn by a very good friend of mine who has a real love for Burma and has worked there. And she drew this for me during this last year. She was working as a nurse in a COVID intensive care unit, and I was working in the emergency department. And it's based on an American cartoon called Rosie the Riveter. And it's sort of solidarity, working together, and being confident that we can do good things. Does anyone have any questions at this point?
Thank you so much.
would anyone like me to go back to the slide? This slide? Does anyone have any questions on this diagram?
Rachel, that's been brilliant. Thank you so much. I think we may get some questions coming up in the chat. I've got another meeting to go to, so I'm going to make you host, if that's okay, because you seem completely all over this.
Okay.
So is that all right?
Yeah, that's grand.
Great, fantastic. And thanks very much, everyone. And we will have some more sessions next week. So thank you all very much. And I'll make Rachel the host. Thanks, Rachel. That's been really great. That's been a really great session. Thank you so much.
Thank you for having me. Just to confirm, I just say end, or do I have to do anything else?
Yeah, just
okay.
just close it all down. Close it all down at the top, or I'll stop it later. No problem.
Okay.
All right.
Thank you.
Cheers.
Bye.
Hello.
Hello.
Hello. Can I ask one question?
Yes. Yes.
Yes, because this triage topic is very good for our country in Myanmar. And recently, I'm working in Mission Hospital. That's why we are faced in a like situation. One day, even in our on-call duty, many 4 patients came urgently. One is bullet injury, another is superficial, and other is smoky, choky, and other is bruising only. So, so can you triage for? Can I advise for? Because of our country condition, we have few staff, and so how to control our situation? Can I advise? You can advise for our situation even if we have a deal-like situation. So can you advise for me?
Thank you so much for your question. It's a really big question, and I think I respect you so much for the work that you're doing in very difficult situations. So
yes, we are very difficult situation we are dealing. So it's coming like that. So it is a few steps on how to deal like situation. So, thank you.
So yeah, like I said, very, very difficult to know where to even start. And particularly if you have limited staff, that makes it even more crucial that you prioritize the persons or the person that needs immediate care. What we talk about in my context, if we have, say, a big traumatic event, so it is maybe slightly different from what you've experienced, but you may have heard of the London Bridge attacks. So in that situation, we had men with knives who attacked a crowd of people in central London. And at that time, my whole department had to switch from sort of normal triage to something we call mass casualty triage. So it's a slightly different system. And Marcus has asked me to maybe talk about that in the future. But it is almost like a more simple version of this, where you are assessing people even faster to determine who needs to be seen right now, who can wait. Another situation where I've seen that system used is when I was living in Thailand. There was a bus, and the bus had an accident, and there were maybe over 100 people on this bus with huge range of injuries. Some were dead when the emergency services arrived, and some had just minor bruising, but all needed to be assessed and very quickly so that they could help the people that could be helped as fast as possible. So with the situation you're describing, you know, when there's somebody with a bullet wound, somebody else with like superficial laceration, somebody else with bruising, somebody who's choking, I think if you're being so overwhelmed with, you know, that many cases at once, that's when I would switch to that system. And like I said, I'd be happy to talk more about that system in another session. But if, you know, the basic principle remains the same, which is although you might have to go faster through your ABCDE, it's about assessing, okay, actually the person with the bullet wound, and again, this is just me thinking of like a simulation. It's not, you must do this every time. It's just, okay, what would I be thinking? If actually their airway is not obstructed, their heart rate is, you know, not dangerously high, they're not having catastrophic bleeding from the wound, then although they need to be seen urgently, they might not need immediate intervention now. Whereas the person who is choking, if you don't stop the choking, then they will die. So it's about thinking, okay, this person urgently needs to be seen, but actually, are they at immediate risk of death if I don't see them right now? And is there somebody else in this room who is at immediate risk of death if they're not seen immediately? But it is a very, very complex and very hard process of decision making. And I think made harder when you're on your own. I don't know about the circumstances for everybody, but I know that some of you will be practicing independently and you may not have a team around you to support you. I'm very fortunate and very blessed that the places I've worked, I've usually worked with either a team of very skilled nurses or doctors as well. So thank you for your question. I don't know if I've answered it as you would want, but
Thank you, Rachel. Thank you so much for sharing.
hello, can you hear me?
Yeah, we can hear you, Richard. Thank you so much.
Hello, are you able to hear me now?
Yes, we can
Oh,
clearly hear
wonderful.
you. Yeah.
Thank you. My microphone has run out of battery, so I've just had to switch.
Oh, sorry. Yeah.
It's all right.
Thank you so much. You've been amazing. Thank you, really.
Thank you.
Yeah, we would really love to have you back for more sessions. If you are okay, we're gonna ask Marcus to arrange for that.
It's been a real privilege being with you guys this morning. I really appreciate it.
Really lovely. Thank you. Yeah. Guys, do we have any questions? I think there is no more questions from us. So, okay. I think we see you next time, Rachel.
See you next
time.
time.
Have a lovely day. Have a lovely day. And thank you so much.
Thank you. Jesu Timbade to everyone.
Thank you so much, Rachel. Thank you.
Thank you. Goodbye.
Bye-bye.
Bye.
See you.
God bless you.
God bless. Bye.